So welcome to Georgetown Village Healthcare Advisory Committee lecture series. And I'd like to introduce the president of Georgetown Village, Jessica Townsend.
Thanks, Lynn. And my delightful job is to introduce Dr. Anya Papura, who is here on my left. How she comes here is a tale of serendipity. It was about 18 months ago, and I was at a party, and we met and we started to chat. And within a few minutes, we were in a corner discussing aging issues. Now, does everyone do that at a party? I don't know. And of course, everyone at the party was very excited about this. But it was clear to me that Anya was someone who has experience and knowledge that would benefit the village. So I asked her to join the Healthcare Advisory Board, which was just being formed at the time. And here she is. Dr. Papura has an MD from the University of Zagreb School of Medicine and a PhD from Iowa State University, the Department of Biomedical Sciences in the Neuroscience program. She's also currently president and gerontologist at Aging Perspectives Incorporated. She's on the faculty of the Washington School of Psychiatry and an adjunct professor at Catholic University School of Nursing. And, well, I think I'll stop there, but there is lots more. Dr. Papura has done 15 years of research on Alzheimer's and dementia and healthcare improvement projects for older people. She's now trying to translate some of the research findings into practice and into real life. And we're very lucky to have her with us tonight. So I'm pleased to present her. Anya.
Thank you. Do you think you can hear me without a microphone? No, okay. Well, first of all, it's great to be here. But I also want to tell you that I had a rough day, and I'm going to probably demonstrate a number of early signs of dementia. So bear with me. So what I wanted to do, because I figured out there will be a variety of people from villages, some who had experience with dementia, some who are just thinking that maybe they will have experience with dementia. So maybe we can start with so I was thinking I will do with some early signs and then go on another spectrum, when people already have dementia and when they, or they're caregivers for people with dementia. One of the greatest issues in caregiving is behavioral problems. And so I wanted to talk on that spectrum as well. So maybe we can real with a show of hands see who had any kind of experience with family members or friends with dementia. Oh, wow. Okay. So there will be plenty of case studies that we can do the second part, because I think that's the best way actually to learn some of these things. Otherwise, I just talk too much. And then, and how many of you are possibly concerned that you have early signs so that maybe you will get there? Okay, well, that's good. Not too many concerns ones. Maybe we can go really fast through some of those top 10 early signs of dementia. So I really wanted, first of all, and by the way I usually give talks and lecture and teach, you can interrupt me at any point in time with questions. We will have question period at the end, but I like discussion rather than me just talking at you. That way you also don't fall asleep. With the wine, I think it's a wise choice. So what is dementia? What do we think dementia is? I mean, do you want to tell me what some of you think dementia is? Okay, so that's something that a lot of us think automatically, and that's one of the symptoms of dementia. It's not necessarily dementia per se. That's why I wanted just to give you a sense that dementia is actually a syndrome, which means is a number of different symptoms, but there are about 50 or more causes of dementia. And normally, most of us, when we think about dementia, think about Alzheimer's disease or Parkinson's or Lewy body dementia. But that's not the only dementia. There are two sort of in terms of course of dementia, there is reversible and irreversible dementia. And reversible dementia would be something, let's say if you have a stroke and you can have permanent dementia, but you can also have part of dementia that it's reversible. And that will, you will regain most of your abilities, or some of them, or all of them. Also, for example, after traumatic brain injury, you can also have dementia that can be reversible, fully or partially. And then we have irreversible dementia, and that's progressive. And that's the one that most of the time we think about, which is Alzheimer's disease is one of the most common causes. Alzheimer's disease causes about 50 to 60% of all dementias, but then Lewy body and and frontotemporal dementia and vascular dementias are other really high sort of players in terms of causes of dementia. So I also wanted to give you a sense how prevalent this is. Prevalence of dementia increases with age. So when in a group of 65 and older, when we talk about population-wise, there's about 10% of people who will have dementia. When we come to 75, that increases to about 20% of the population that's 75 and older. And then we come with 85, then it's 40 to 48%. So it's almost half of the population will have some level of dementia. And when you think about, in terms of healthcare and in terms of our future as a society, by 2050, year 2050, we are estimating, statistics on populational statistics estimate that there will be about quarter of population 65 and over. And out of that, about quarter of those 65 and over will be 85 and over. So we're going to have a huge explosion of this issue as our silver tsunami is getting more power to it. So, and the other important thing for me to always give a sense how much are we diagnosing or not diagnosing, or how much is we are actually addressing, even when we know, is to give you, because I think even as sort of like in a community, especially in a community such as Village, we can be a little bit more proactive in trying to get people to maybe screen themselves and do something about it. That we have that there are some studies that looked into actually Washington, D.C. metropolitan area assisted living specifically, and they saw that about 25 to 30% of the elderly affected with dementia remained undiagnosed. And only a little bit over half of those who are diagnosed are actually appropriately and adequately treated. That doesn't mean they were not treated, but they're not, not in their full potential of treatment. So those are really some discouraging numbers. And when you think, also there's another that's not written here, there's another statistics to say that most of people get diagnosed in mid-stage dementia, moderate level of dementia, and they have seen physician. The vast majority of those people have seen their physician within a month of the diagnosis, and they were not diagnosed at that time. So it also tells you how sophisticated people with dementia can be in terms of fooling us around and compensated for some of the losses. Yes?
When you said diagnosed, say you have an annual physical with your internist, and is that the doctor who's supposed to diagnose you?
They can diagnose you. They can at least screen you. And I think, unfortunately,
Screening is at a certain age?
I advocate for that, but it's not. And I think that's part of. I think it would be really easy to start at 65 and over, make it a regular. There are little tools, 3-minute test that it can be done to have a sense whether something is going on or not. There are other tools that are more in depth. And it would be really easy to put it in all the tests that you do it on the annual exam, and first of all have a baseline so you know where they are every year after that. And second of all, a lot of times people who are in early stages, they are in denial. They don't want to know, and they don't want anybody to test them. So then when you approach them, oh, you're forgetting, oh, you're doing this and that, they really refuse the testing. And if you normalize it that everybody of a certain age needs to do that, then it would be a lot more easier, and it would be just another test that we go through. So I am a big advocate of screening for dementia and depression and anxiety in older people. Yes?
My experience has been, what my doctor told me about this is that you have to ask. The doctor has to be asked if there's going to be any testing done for that kind of thing, which is, if your patient is in denial.
Exactly. It's not going to happen. And I had experience with people who were difficult in terms they were rejecting testing, and one of the things that was successful is if you change a physician, that the physician says, this is part of my screening when you come as a new patient in my practice. So I think it would work, but we are not there. I mean, that's part of, I think, advocacy of people like you who belong to villages, that we actually can advocate as consumers as well. Yes? Oh, the question.
Each time.
Okay, I will.
What I wanted to say is you could go to a neurologist and they would give you the test if you were concerned.
Absolutely, but that doesn't. That means that a person needs to be aware, a person needs to be willing, and before you actually go there. The idea of screening would not be a final diagnostic tool, but would you give you black and white something to say there is high probability, and then primary care physician can refer you, and then there would be a lot less sort of pushback from people who are in denial.
What was the question?
Oh, sorry. The question was, actually it wasn't a question, it was a comment. Then one can go to neurologists to get a diagnosis, and generally, but then you heard my answer. And it's true, in terms of diagnosis, that's really who most of the time, memory clinics, neuropsychiatrists and neurologists are the ones who are actually diagnosing the dementia. That doesn't mean that others cannot do it as well. Yes?
I just took a wellness test for Medicare, okay? Which is why I asked the question. And so that should be on the list, and that's not on the list of all the things they're supposed to check. And if the villages did do something together, that would be probably the easiest way to get it on the doctor's docket, is to push Medicare to add that.
Okay. Oh, did you hear that? Okay. So Sarah was saying that she just took a wellness test for Medicare, and that was not on a list for primary care physician to do that, and that could be one of the good ways to actually advocate for some of these screenings, to have that pushed from a Medicare side, sort of on a point of care. Yes.
In the screen before this, you had an abbreviation, 2 capitals.
Oh, AD.
What does that mean?
Alzheimer's disease.
Sorry?
AD is abbreviation for Alzheimer's disease.
Oh, I see.
Lewy body dementia is another one of a type of dementia, and then we have frontotemporal, used to be PICS. It's a different kind of disease that causes deterioration, of different type, sort of physiologically, and on the brain you will see a different picture, and there's sometimes some of the change, different course of illness. But I think for the purposes of our talk, that's kind of not so important, because we have limited amount of time and we don't really have to worry, because the symptoms at the end, the group of symptoms, which is a syndrome, is the same. It's dementia. Yes?
One more question. You said Alzheimer.
Mm-hmm.
Is this name a German?
That's from Alois Alzheimer's. No, it's a man. Alois Alzheimer's was the one who first discovered the Alzheimer's disease. He was the pathologist who was slicing the brains, and he found the plaques and sort of the hallmark, pathological hallmark of the Alzheimer's disease.
Was it German or Austrian?
I don't. Honestly, I don't remember. That is okay. So what are general symptoms? You know, Sarah, I think you said when I asked, what do you think when I say dementia, it's memory impairment. So learning, recall, processing speed, those are some of the memory impairment and cognitive impairment issues that we see. I will talk about implicit versus explicit memory because that's something that's very important to me and something that I always like to impress on whatever audience I talk to. Implicit memory is emotional or muscle memory and muscle memory. So implicit memory would be you see your toothbrush and you sort of just know what to do with it, or a bicycle. You don't know that you can ride a bicycle, but if you get on a bicycle, you know what to do. At the same time, this is emotional memory, how we respond to somebody that we know and we love differently than somebody that sort of feels in danger. So, you know, smiling and happiness and sadness, those are emotional memories. And then explicit memories are memories that are for facts. You know, what day is today, who's the president, so that's like really what season is it today. What happens in dementia is that explicit memory goes away faster than implicit memory. And the reason why I'm stressing that is that even when people are in very severe stages of dementia, they can still respond to certain kind voice, to smile, to non-threatening way of talking to them, even if they don't understand anything, if they can't process anything in terms of actual meaning of the words. And that's something that it's really going to be important later on when we talk about behaviors and how we deal with some of these difficult behaviors. And then we have functional impairment, instrumental activities of daily living. These are higher level functioning, like can you actually prepare your meal? Can you balance your checkbook? Although some of us can't balance it even without dementia, right? But, and then activities of daily living as the more basic tasks. Can you ambulate? Can you go to the bathroom? Can you walk by yourself? Can you go to the bathroom? Can you actually dress yourself and bathe yourself? And then speech and language also gets deteriorated. And you will see one of the earliest signs of finding words. That I'm going to demonstrate for sure by the end of the night. And sometimes not understanding always the words that we say. Or using words that are kind of descriptive, but not really correct words for what they're trying to express. So we also have to be very attuned on all kinds of words and meaning beyond the actual meaning of the word itself in order to understand what they're trying to communicate to us. And then there are mood changes and behavioral changes that we're going to talk about later. So for those few that are possibly, so we can go fast through this, they're possibly worried about the dementia. These are 10 early signs, and I have some handouts here. Later on you can take it. This is from Alzheimer's disease, Alzheimer's Association. This is basically kind of can be something you can take to your physician if you're worried, and sort of a checkpoint to look at the 10 early signs. Memory loss disrupts daily life, challenges in planning or solving problems. And you know, when we do these kinds of things, clearly we all have individual differences in the first place. Some mistakes, these are not absolute rules. You can always make mistakes. I lose my car all the time in a parking lot, have no idea where I parked it, but I have ability to figure out where I parked it. The moment I lose that ability, how to possibly retrace, what to do about it, go for help, or press my remote button and hear my beeping car, that's going to be a problem. I'm not going to worry if I keep losing the car because I've been doing that for years. And So confusion of time and place, clearly not quite knowing where you are and what time, whether you're oriented on trouble understanding visual images and spatial relationships. This is part of the processing. This is not actual visual problems, but really processing the visual images and sometimes not being able to recognize or find words. What exactly did you see? What's that in the brain? What does that represent? New problems with words in speaking or writing, misplacing things or losing the ability to retrace the steps. And a lot of times, for example, this one, misplacing things or losing things and not being able to find will then cause paranoia. And the people with dementia will then try to sort of fill in the gaps and say, oh, somebody stole it. And then they'll become really accusatory of others around them. They stole it, they put it somewhere, they trashed it, and this or that. Decreased or poor judgment. So it can be some, decreased judgment, good judgment, withdrawal from work or social activities, and changes in mood and personality. A lot of depression and anxiety extremely prevalent in people with dementia, much more so than in general population of the same age. And this is actually, I guess, I just wanted to tell you, for example, in general population, there's about 15% of dementia, of depression, and about 20 up to 80% in people who have dementia. And in anxiety, we have about maybe 20% up to 20% subsyndromal and that impair regular everyday functioning, but in dementia it's up to 70%. In fact, prevalence of depression and anxiety and paranoia is so high in dementia that we think it may be sort of prodromal sign, so one of the early signs to catch that maybe they do have dementia. Yes?
I see that the previous fact that there are more women than men, but women live longer than men. Yes, men is 17%, women are 21%, but there are a lot more women than men over 65. Standardized for age, is it more likely men or women?
It's more likely, women are generally more likely to be anxious. For example, but on the other hand, in depression, I believe it's also slightly more women are depressed, but men have higher suicide level. So it seems for depression, if they get it, then it gets really, worse, much worse than in women. So now I wanted to go onto sort of a second part of a talk, which talks about behaviors. I call it agitation, because that's the term that I used in my research, and I also think I like it better because it doesn't have judgment appended to it. Because a lot of times we call them problem behaviors, neuropsychiatric symptoms, behavioral disturbances, resistive behaviors, all sort of have a little bit of a negative connotation. And I just wanted, so the agitation is quite prevalent. We have about 40 to 86% agitation in people with dementia, depending on setting, somewhere higher than others. And 65 to 72 actually express aggressive behaviors during personal care. So this is another major issue because a lot of people with dementia, and I mean not just that they have dementia, but they're also older, they will have difficulty of taking care of themselves for other reasons, not just dementia. And then if you try to help them have regular care, daily care, like going to the bathroom, putting the clothes on and giving them showers, that's where a lot of injuries of caregivers are also going to happen, professional and family caregivers. So the definition that I use for agitation, that those are inappropriate verbal, vocal, or motor activity that are not visibly caused by confusion or needs of the individual. And we have 3 types. And I'll tell you why this is important. We have verbal, physical non-aggressive, and physical aggressive behaviors. And the reason why they are separated like this is because the whole body of research actually showed that these kinds of behaviors that common sort of etiology, meaning common reasons to actually happened. So then it's easier if we put them in one of these groups, then we can sort of figure out what would be the treatment. We can sort of troubleshoot the behavior this way better. So I just want to quickly go through why is it important, and then I would actually, and I'll give you a sense of what are some of the theories of explaining agitation in dementia, and then I would like some of you that had family members or friends and experience with this to give us certain examples, and then we can go through some of the, maybe answering the questions, what can one do in certain situations and with certain behaviors. So the agitation is a huge issue because, first of all, if you look at it from a perspective of person who experiences dementia and who demonstrates these behaviors, is that there is some need that we clearly don't understand and then we didn't provide for. Increases caregiver burden and injuries, leads to pharmacotherapy of psychiatric drugs that are not necessarily specifically, they are not etiological treatment. It's just there sort of to calm down the behavior. And then we are much better about this, but it can actually lead to physical restraints as well. So some of the theories are direct impact of dementia, which basically tell us that dementia has certain, pathophysiological substrate, meaning the brain changes, and that's the reason why we have these behaviors. Then we have behavioral model, which tells us that each behavior has a consequence. There is actually antecedents or trigger of the behavior, and then depending on the consequences of the behavior, we'll either have behavior stop or it's going to increase. So that's so-called ABC model, antecedents, behavior, and consequences model. And then we have environmental vulnerability model, which tells us that when you have dementia, your sort of threshold for for processing environmental stimuli is lower, so that you're going to sort of blow up on a lower level than others would. And then the unmet needs model that I really like the most, and I'm showing you a picture, is the one that I subscribe to and I work with when I work with people who have dementia and I'm asked to help with difficult behaviors, because it doesn't exclude any of the other ones, but it really looks at the person as a whole. So what unmet needs model is saying is that we have to look each person as a person with all their lifelong habits and personality, so who they are, with their current condition, physical and mental, what are their ailments of all kind, and then what is in their environment. And when we talk about environment, not just the physical, but also psychosocial environment. And all of these define the person and their needs. And depending whether we have then figured it out, hopefully we do, but if we don't, then we're going to have unmet needs. And then the behaviors are going to exhibit themselves partially as fulfilling the needs. One of the examples of fulfilling the need is pacing. Sometimes people with dementia will just walk up and down non-stop. And one of the needs is that they need really more stimulation, more physical exercise. In fact, I had been in one of the nursing homes years ago when I walked down the hall, and one of the residents was going up and down, and she said to me, I don't kind of know what to do, so I just go up and down. So she was even able to sort of express her need and to tell me why she's doing it. But it's a classical example of actually behavior that fulfills the need. And why is that also important to understand is so that we won't suddenly expect her to sit because we think it's not okay to walk around up and down the hallway. Behavior as a means of communicating needs. I mean, they are trying to tell us something. We just have to figure out what exactly are they trying to tell us. And then, of course, behavior is an outcome of frustration and fears and a decreased inhibition. So at this point, I have 3 charts like this for each group of behaviors. And they're just way too busy to really need just talking about it without any context, real life context. So if we have any volunteers who want to tell us a little bit about their experience and what kind of a problem they have encountered, then we can go through this and we can figure it out together.
I will tell you one anecdote about my mother who was...
You know what?
And,
Why don't I do this? Hold on a second. Because I don't think I'll be able to repeat everything you say.
well, I didn't want to do this, but call attention to myself. Anyway, what I was saying is my mother was suffering from Alzheimer's. And, I would come visit her, this before it was extreme. And I test her on her use of language. And she was clearly, if you will, aphasic. But the interesting thing was that she would forget concrete nouns, like chair. What is that, Mom? That's a sit in it.
Mm-hmm. So she knew the function, but she did.
At the same time, she could use much more abstract nouns correctly. What I can, of course, think of the example, but that's not important. And I found that really very interesting is all. She exhibited a lot of the things that you're talking about, and for example, paranoia, and I wondered if that wasn't a combination of dementia plus other syndromes, say. And but as you explained it, it's part of it. And she would get. Well, I don't need to go into the whole story, but I just wanted to say this is an interesting example of aphasia and the way her mind worked, and she could not think, as I said, of concrete nouns. She couldn't express herself that way. But when it came to the abstract things, she could express them much better. The other thing is that although she was Swedish in background, and she'd learned a little Swedish as a child, she often, as you're not surprised with this part, she would often bring up Swedish words, not to speak to me, though she didn't really recognize, but just she'd remember words, recall them.
Actually, that's part of in bilingual or trilingual, multilingual, whatever people, what's going to happen, they're going to start losing languages they learn later in life. So they will, if I'm lucky enough to get dementia, I guess at the end I'll be starting talking Croatian. That's my native language. And I had clients like that when they would speak Slavic language, and then I sort of figured it out because and they were English speakers and they could do some of the English, but as you go along, as the dementia progresses, we lose function and memories in order, memories in order of acquisition, in reverse order of acquisition. So something that we have learned more recently is going to go out first. So that's why at some point people will actually look at themselves in their picture and they'll think they're their parents. Because they sort of went back in their memories and now they have a picture of themselves at the younger age. So clearly this older person is not them, it's their parent.
They lose difficult sounds too. In Czech, the rs sound like in Dvorak. As the people get more and more demented, they cannot pronounce that anymore, which they should.
But the other thing that we have to also remember is they can't always understand us. Just like your mother knew what the chair is for, which is kind of partially implicit memory, not just explicit, because naming it is explicit memory. Knowing sort of what to do with it is implicit memory. We also have to remember that they may not understand us. And when you lay out clothes for them to put and say, put your pants on, they may look at those pants and have no idea that those are the pants. And they don't suddenly know what to do. So we have to help them cueing stuff. Like actually give them, help them take the pants, and then they'll sort of know the function, okay, now I need to put my feet in it. Yes?
To go back to your point about some of the personal care issues and then some aggression or irritability with that. And my mother has been diagnosed with dementia. It's called uncomplicated senile dementia. So, and she's been tested twice, 2005 and 2012. So I've seen this progression somewhat over time, but this issue of personal care, like showering or not so much the dressing, but maybe the rest, going to the bathroom and
toileting,
toileting. I think the frustration is also, it's just an issue of personal dignity, because she has enough memory to know this is very personal, and it's something that she wants to do herself. And so the irritability is not, well, it can be the dementia, but I also think it's that she still knows that that's very personal and she wants to do that herself, whether she can.
You're absolutely right.
And so that's kind of a fine line there, recognize that.
You are absolutely right. You are absolutely right. And a lot of issues that we have with behaviors, and I just put it here, it's part of the control issues, because even if there are other things, I mean, I think of personal care is something so intimate, and you feel so, literally and figuratively naked and vulnerable, that's why it's, has higher level of agitated, and then we really go into sort of more serious agitated behavior, which are aggression. But it really, most of it comes from fear and anxiety, and we are really invading their privacy. We are invading also their, independence. And this is why it's important how we do things and how we present it and what are the options for this care. And even when people are not able to do their own personal care, I always say that some function of it, even if it's just there to, put the washcloth and put it over your body a little bit, that we always have to provide that for them, regardless how functional it's not, because it gives them sense of control, and also we give them options. Do you want this or that? Do you want this soap or that soap? Or do you want to shower or you want a bath? Any kind of control and play back and forth, and sometimes you allow them to reject you, and okay, you don't want a bath now, you can have it later, and then come back. So to give a sense of control. And it actually works, and there are different kinds of ways of providing personal care. With non-drink soap, we can be sort of massage type of thing. There are clinical trials out there that show that they work well, reduce agitation, and actually are even better in terms of skin integrity and cleanliness, because they don't fight you, so you can actually do a good job.
I'm very intrigued about your explaining the implicit and explicit memories, because that's totally new to me, and I find that interesting. And so it leads me to ask you to comment on how we communicate with people who have dementia, particularly people who, for example, have lost their speech, people who may have no affect when we're with them. I think many of us have had an experience of a friend or a relative being visited by an old friend who then leaves and said, oh, she didn't know me. And I have to say that reaction, when I was confronted with it, angered me, because I thought it was that person focusing the whole experience on herself and not on the patient. And my sense has been that we don't know what the dementia patient knows or understands. And that there is no reason, when my mother had dementia, why we shouldn't stop talking to her and telling her everything that we wanted to say to her, because why not? Anyway, can you just comment on that kind of, what I think is a responsibility of a caregiver?
I think I agree with everything you said. In fact, I have done a research study on preservation and salience of self-identity in people with dementia, and we've shown that even in severe dementia, there are self-identity, it's preserved. And family, especially family role. We looked at different sort of 4 domains. And I think you hit nail when you said that it's more about, people are sometimes really more focused on their losses and how they cannot deal with that. And then in that process, they sort of reject and project into person with dementia. And so we need a lot of education. I mean, I have been faced with that in a way in my personal life because my son was trained to do the visitation without dogs by, PAL, which is dog organization. But they didn't really teach him how to deal with dementia. So when he went to some nursing homes, these were more nursing homes who didn't deal so much with dementia. And then when I took him to one of the places that I work with, he was totally drained. And he said that, they don't have, what did he say? They don't have a happiness in their life. And they got it on me. So I had to train him so that, the eye contact is really important. Having smiled, what I was talking about implicit memory. These kinds of non-threatening way of talking, even if they can't understand the word, but melodic voice will actually soothe them down and they'll respond to. And we have to carry on conversation. What you said, there is no reason, we don't know what's happening. And I believe that there are a lot of different things happening in there. They just can't clearly tell it to us, and we don't know how to understand. Because when I did a study on self-identity, we didn't look only what they were telling us. We actually did observation, and we looked their responses based on their behavioral responses. In other words, if a complete stranger came to them and said something, they will have certain response, facial expressions or body language that is going to maybe indicate that either they are neutral or they may be anxious or they're just reserved. When a family or somebody that is really close to them and they cared about, they'll have smiles. They may have no idea who this person is in their life, what the name is, what their relationship, but they react differently. So we have to be very keen observers. We can't take everything for face value. Being on an eye level, I spend when I am with people who are in nursing homes and in sitting in the chairs, I spend a lot of time on my knees and talking, on their eye level, an appropriate tone of voice, an appropriate pitch, and as well as we have to talk a little bit louder, but we should not be yelling either. So those are all very, very important components. And I think individualizing some of the things in what they do in activities, in what is really important to them. That's that part in that unmet need. Who's this person? What are their habits? What is their personality? What do they like? If I want to engage somebody with dementia who loved opera and I just put rock and roll, I don't think it's going to work. It's not going to tap into that in that implicit memory. But if I put something that they were really connected, there has emotional valence for that person, they will actually start either humming or actually remembering the words, lyrics of the song. So it's actually amazing how through different sort of multisensory interventions, we can tap into the memories. It's almost like we are, experimenting which, pathways in the brain are still working and connecting to each other.
This is kind of a shift to the interests of people who, there might be a good number in this room who are at a stage where, they're forgetting things and so on, as you referred to earlier in your talk. Have you been connected with any research, or can you give any advice about the tools that are helpful, or are tools helpful for those of us who are realizing that we can't carry out certain cognitive functions in the way we used to?
There's a whole bunch of research on how can we, we can't, if it's a progressive dementia, we can't do anything about it in terms of it changing sort of the course, but we can make a difference in independence in everyday lives. So for example, it's good to have certain routines, because we can easily sort of follow those routines and they can be learned. And it's one of the myths is that people with dementia cannot learn. There are ways of sort of cognitive rehabilitation techniques that we can use to actually relearn or learn some of the new things. Reminders. You can put it on a wall, or you can have voice reminders, recording reminders, what to do. Those are all kinds of things. One of the early interventions can be like people doing crossword puzzles, like making yourself remember and redo certain things. Doing memory books, or your narrative history of your life, or those are also very good, and it can be incorporated together with the cognitive rehabilitation technique. So if you don't know it at that moment, you can actually repeat it. There is a specific way of working, so they can actually remember that more. So those are some examples of how to deal with it. Yes.
I use the word tool.
You.
I have to go back. Just a footnote to the comment before last, which was one line. I have an old friend who's a geriatric physician who's also an Episcopal minister that turns out is kind of an overachiever. Anyway, and my sister and I met with him as our mother was coming down with actually it was a vascular thing that got her into the dementia, and she was a very happy camper the whole time through, but she was as she was going into it, it was very difficult. She was very agitated, but then she went into it suddenly and she was just floating along. But our friend said, the doctor, who's also the reverend, said, you're dealing with a totally different person. You have to forget the mother you always knew. You have to forget the mother you always knew and deal with this other being who acts in a totally different way. And that really, for us, it was very liberating, because we just didn't have any expectations that this brilliant woman would, why don't you answer us, that kind of, it just wasn't going to be anymore. So we just sort of like dealt with her in her own terms, and that was a great help to us.
I would agree and disagree.
Okay.
I would disagree that forget about the person that you knew. This is a completely different person, because I just mentioned to you that we actually done research, and there's a significant amount of self-identity retained, even to severe, in severe stages of dementia. What I think it's in a way good advice, because it liberated you. You didn't have these expectations. A lot of times what's happened when we also try to engage with people with dementia and they can't sort of perform, they can't do the correct, we get frustrated, and suddenly, that frustration obviously transfers to them, and it's not a good visit or good story. And I think if you don't have, if the expectations that they're going to engage and be there with them, then you are on a, really have a good start.
Going back to the issue that the woman in the front row talked about, you hear about doing crossword puzzles, luminosity. I mean, are there And one believes that if you work at these things, that your memory will improve or maintain itself. What I hear from you is that if you're going to have dementia, you could do many crossword puzzles or do luminosity 100 times a day, but if it's going to happen, it's going to happen. Am I wrong?
Well, it will happen. It's inevitable. Just like we will have to die. That's kind of the only guarantee we have in life, right? But you can make the quality of life and you can make the decline a little bit slower. So you have a higher level of functioning for longer time. Because if you do some of these things, if you make certain changes in a household, for example, so that you're reminded when to take your medications, that you're reminded, what to turn off the stove and things like that, then you're able to stay there sort of independently for a longer time. And that's quality of life. And I think that's also, I think for me, that's a really important issue, that we know so much. Some of the things I'm telling you, it's really about quality of care and quality of life. We know so much about that at this point, yet we haven't translated it into practice. And we are just waiting, for miracle cure that we are going to, there's huge amount of research, beautiful stuff going on, but we are not there. We're not going to have a pill that's going to solve all the problems anytime soon. So we should use the knowledge that we have to increase quality of life versus, just wait for the miracle cure.
At the beginning you talked about underdiagnosis and late diagnosis. And this conversation here makes me wonder what the advantage of early diagnosis would be.
Well, I think there is certain parts of planning that are important. I think, in terms of processing it and grieving, because aging is all about grieving. It's, every new beginning, regardless of what stage of life you are, every new exciting beginning actually has ending before it of something else. So you have to go, we constantly grieve and look forward to something new. But as we age, we have more and more losses, and it's a change for all of us. So I think it's really important to address that and to plan sort of what you want, to also plan for some of these interventions that we're talking about, early interventions. Where do you want to be? So there's a lot of things I think that we can, it's different from, I have early, diagnosis of breast cancer and therefore I'll be cured. I'm not going to be cured, but there is a process, it's a very long process of having dementia. By the time we get diagnosed, that we actually have symptoms, it's about 15 to 20 years of the process going on already in our brains. So, and then people sometimes live very long with dementia.
Going back to the beginning, how should we react if we don't have dementia? There should be a baseline. Should it include a neurologist? Should it include an MRI? What does a baseline look like?
I think some of the screening instruments are really enough for your baseline. Mini cogs, that's actually diagnostic mini cogs, but it's a test. Mini cog it's a screening test. I ask you 3 words, we could do it. It's not a group test, otherwise I could do it. It doesn't work if I ask the whole group and then you help each other. And you draw a clock. And then based on how you drew the clock, because you draw a clock and then you have to put a time that we ask you, and then depends how that all looks like, you can tell us whether, something is going on or not. There are different kind of tests, mini-mental. There are all kinds of different tests of cognitive. They're relatively quick, and your physicians can do it, and you can have it in your chart, and then you would see the No, you don't need them, all right. Yes, Alzheimer's is like with a plaque. Yeah, but there are plaques in some others, and in fact, as we age, we also get a plaque even when it's not Alzheimer's. Yes.
If you see some sign that you suspect some things that an individual might have, and you talk to a practitioner about it, this person is doing this or that, is it possible to predict what the person might be like in, say, 5 years, or is that just so random there's no way to know?
It's very individual, and so it's difficult to say. And the other issue is also, we now know, a few years back, we decided there's a minimum cognitive impairment diagnosis as well, which is kind of early dementia, but it doesn't have to progress into dementia. A lot of people who have minimal cognitive impairment will progress into dementia, but not all. So it's just difficult.
Could you speak for just a moment of how nutrition might make a difference?
Okay, we have red wine and all of that. We don't have, in terms of nutritional supplements, there is no, ginkgo biloba was big, now they're talking of, there are not really definite, certainly healthy diet and exercise is good altogether. It seems that actually what makes more difference for dementia is psychosocial interactions and intellectual stimulation. So make sure that you go out with friends, you work really hard at brain. And so I have another job that I do with scientific peer review, and I always think that's my dementia prevention program, because they throw me into these panels that it's not my expertise and I have to figure it out. So that's my dementia prevention program. Yes, I have to stretch my brain, that's right.
I'm wondering if one of the signs of early dementia would be lack of curiosity and lack of desire to learn new things and do new things and experience new things, and not really have a curiosity in asking questions and simple conversation.
Yes, actually that in a way covered with some of those 10 signs over there where we covered, because that's really, if it's a different from before, if somebody was not ever curious, it has to be different from what you know about this person. But if there is suddenly decline in curiosity, decline in talking to others, they can definitely be an early sign. However, I showed you also how much of depression there is in general in older population. Sometimes you have to sort of figure out whether it's combination of depression or dementia, or is it just depression? Because sometimes if depression is quite severe, it can look like dementia. We call it pseudodementia.
You mentioned drugs early on. You had that on your list. I was sort of interested to know what drugs are available and what their benefits are.
Okay. What I mentioned about drugs is if they will use it, those were not really drugs for dementia per se. Those were psychoactive drugs, like if you are agitated and we can't figure out, then they usually call psychiatrists,
But that's part of it. Dementia.
Well, it is part of dementia, but I am a strong believer that if it's not a true psychiatric symptom, then it shouldn't be treated with psychiatric drugs. I'm big on non-pharmacological. I'm not saying that at times it's not helpful to have psychiatric drugs to sort of temper it a little bit and to give us time to figure out non-pharmacological, but tapering it off really quickly, because if you subscribe to the idea that these are all unmet needs, then we need to figure out the needs, not to sort of just muffle the behavior. Okay, you go there now.
There's kind of an impression that we're talking about dementia as something that is an inevitable decline. What about the cognitive impairment that occurs because of a stroke or an injury? Is that part of your research? Do you apply these same ideas or not?
I have not, per se, done research on dementias that are other than neurodegenerative dementias, but I have, in practice, when I was asked to consult, apply these principles on people who have, let's say, Parkinsonism that's not without dementia, but then they have complications and they were agitated, and it works. But that's my sort of anecdotal. I don't have a large clinical study to tell you that will work, but it makes sense to me because I feel, even though this comes with what I was showing you, this comes with the backing of clinical trials, non-pharmacological clinical trials. It's also, when you look at it, it's very much common sense. And I fear sometimes we don't have enough. Common sense is not so common.
Well, just to say that the decline, the inevitability of the decline, it would not necessarily be the same from a stroke or an injury, a traumatic incident.
That's correct. That's what I said in the beginning. You can have irreversible and reversible. However, you can also have, like, from the stroke or sort of like small strokes, you can have permanent dementia as well.
I don't suffer yet from dementia, I hope, but I very much suffer from hard of hearing problem. All what you have on the screen, could we have a handout?
We have it here.
So we can take a handout home.
Here, yes. You can have this.
For me?
Yes.
How about the others?
Well, we have more.
Thank you very much.
I'll just ask you a quick question. Would you have yourself tested for the ApoE4 allele?
ApoE4 allele is a gene that it's connected with a higher prevalence and higher risk of dementia. If I had, for example, history in my family, I think I would. I don't have any history, just like I'm very religious about mammographies because my mother died from breast cancer. I think part of it, we get primed with what's in our families and what we are worried more about.
But you're saying if you had the gene, there's nothing that we can do today that would all...
It's a personal choice. That's correct, but it's a personal choice. A lot of people, there is some research indicating that there is more anxiety while you're fearing than after you actually get a diagnosis. Because then you have a beast that you can attack and you can deal with versus the unknown, the vast possibilities of unknown. Yeah.
So, one more to go back to the implicit memory, and this is a personal example again, but my mother fell and started physical therapy 3 days a week, and then she was like in the swimming pool 2 days a week. And during that process, it seemed that her memory and her confusion decreased. I mean, she still has confusion, but there's been this kind of remarkable clarity in her language that's come about, and also just so she's very, much more cheerful and optimistic and that kind of thing. But she was also always very athletic, and they gave her some of the routine exercises she couldn't do, but then they gave her a tennis racket and with a very soft ball, and she was like, backhanding and forehanding and all this kind of thing. And it's really made quite a difference in her cognitive abilities. Is that something that is, I'm sure it's not permanent, but it seems to, as a management tool, it seems to be.
Well, first of all, she's engaged.
She's engaged.
Did she And you said that she was athletic, so this is part of her identity. The therapy itself was actually an intervention to tap into her identity. The other big issue is, you saw the numbers for prevalence of depression with dementia. It's very possible that she had undiagnosed depression as well. And with exercise, ouch. I just stepped on. Exercise actually helps with depression. There is some research that shows that about 30 maybe minutes a day of just walking will actually help with depression. So I think there's a number of different sort of aspects of that therapy that actually worked for all kinds of reasons.
Just to follow up on that, I've heard that dancing is one of the best things you can do to help your brain from
Learning steps.
Yes, learning steps, using your body, using your mind.
Well, I think it's a combination, I think, of what we were discussing up to this point, right?
Sorry?
It's a combination of what
Yes,
we were
right.
discussing at this point. And the other thing is, like, there is modality, for example, dance therapy, that you actually work and the movements, express also emotion. There's certain emotional expression through that as well. Okay.
Do you have a few practical tips for people who are living with someone with mild dementia at that point in time that can make things better in a relationship or when you're with someone?
I don't have a blanketed statement, but if you have a specific question, I can...
No, I just meant general day in and day out living tips when you're living with someone.
I think, first of all, caregivers need to go and get help for themselves right away. I think that's really important. Caregiver burden is a huge issue. Caregivers are reluctant to go and seek help. So respite care, I think it's very important because the way I see it, the caregiver cannot take care of the patient if they're going to exhaust themselves. And in fact, there's about 40% of caregivers die before the care recipient.
I'm talking about mild.
Doesn't matter. Even the people with dementia, when they go into their assisted living or nursing home, the caregiver burden doesn't stop. There is statistics and research showing that one hospital admission, will actually increase the risk of death in a caregiver for 2 years, one admission, because it's a huge stress. And so I think if anything, I think that caregivers need to start taking care of themselves immediately. So they have resources, because we all have finite resources in us. I mean, and I don't mean now financial, but caregiving does deplete you financially as well.
Okay, I think we have time for 2 more questions. We'll take Tom and Pat.
Oh, I'm sorry. She was first, I thought you forgot.
And then we'll...
I have a Down syndrome sister. She's 62 years old, and about 2 years ago she began to show symptoms of dementia, and I'm wondering what the relationship is between those two diseases.
Actually, early on, that's what it was, because of the high increase of dementia. There was a lot of studies on the chromosome 21 and how does increase levels. So they do have increased prevalence of dementia. And it is, in a way, sort of similar. I mean, the symptoms are the same. So you can apply all of this. And I have consulted on one case that was with Down syndrome. And the principles worked there, just as would be in somebody who has dementia who doesn't have a Down syndrome. And I guess that's the last one, right?
Actually, this might be something Lynn was going to say anyway. Georgetown Village has a caregiver support group, and I just wanted to make sure that people are aware of that, or if not, to get involved if it suits them.
Thank you. Well, that was cut my closing remarks a bit. So I started the evening by welcoming our neighboring villages, and I neglected to welcome some of our professional partners that are here today. Dementia is a very important topic, and it's something we're all still learning about. And I'd like to point out to some of our members and to those of you who are here that we have professionals here from Vitas Hospice as well as from Home Care Association, both Liza and Makia and Jihan, who are joining us to learn as well. And we work with them, and they are here for you if you need extra help. And so I appreciate the fact they're here and they're learning, and I think that's great. And I wanted you all to know about that. Of course, we definitely want to thank Anya, who has done such a fabulous job this evening.
You actually have somebody from professional community over there from Methodist Home of DC.
Oh, I am sorry. I did not realize that. Welcome, and thank you for coming.
Thank you.
And so there's a lot to learn, and I think you've certainly opened the door and certainly started us learning. I know this is not all we need to know, but it's certainly a great start. And so please join me in thanking Anya for this evening.